Good afternoon. Thank you for inviting me to speak at this meeting regarding the question CAR-T versus autograft in large B-cell lymphoma. I'm Dr. Robin Sanderson. I'm a consultant hematologist at King's College Hospital in London, and I run the CAR-T program there. So these are my disclosures. So just a reminder of the landscape for CAR-T in lymphoma. The two products that have been available for a number of years now are Axi-cel and Tissi-cel. Obviously, they have slightly different mechanisms of action in terms of their co-stimulatory domain, but their target, CD19, is the same. The companies are different. And Axi-cel is available for second-line and third-line large B-cell lymphoma and low-grade lymphoma. Axi-cel is the same construct, but with a slightly different manufacturing because the T cells are enriched. And this product is available for ALL and mantle cell lymphoma. Liso-cel is an interesting product because the manufacturing is slightly different. The CD4s and CD8 T cells are transduced into CAR T cells separately and put back together at the end, 1-to-1 ratio. Liso-cel's only been available in the UK on clinical trial. It's not currently available commercially. There's limited countries, I think, giving Liso-cel commercially, Germany, USA, but most countries do not have access yet. I think most people who are familiar with CAR-T will know this, and I suppose I'm just highlighting some of the key points when we're thinking about a patient having a transplant or CAR-T, because we've been able to modify this pathway and improve this pathway as much as possible. Patients, if everything goes okay, can actually spend very minimal amount of time in hospital now when they're having CAR-T. So we allow patients to stay within 2 hours of our hospital if their home is within 2 hours. So we would give lymphodepleting chemotherapy and CAR-T infusion in our ambulatory care unit. Once we've done the CAR-T infusion, patients have to be admitted. We admit them for 10 days as a minimum, and then they would go back to ambulatory care follow-up. So now patients can get through the CAR-T pathway actually by only being admitted for 10 days to our CAR-T ward, which I think is a significant improvement compared to when we started the program, and probably a better patient experience than most patients having autologous stem cell transplants, for example. Also, I think it's worth highlighting that CAR-T patient is not the same as an autograft patient. Some of the lines here are really a product of what's demanded of us in terms of CAR-T eligibility in the NHS, specific products, but certainly enough for a transplant, or they would not be allowed on the contour CAR-T trial. It's very easy to become ineligible for a CAR-T trial. Tissi-cel, the data is a bit different. So the 12-month progression-free survival for patients that received Tissi-cel was 27.4%. If you look at Juliet, which is the pivotal trial reducing the license, that number was 31%. So again, fairly similar to the trial outcome, but obviously significantly less than what we saw with Axi-cel. So this perhaps is the reason why there is now a strong preference to giving Axi-cel in the UK. Again, there's been a lot of head-to-head data done now in a variety of forms. This was an international meta-analysis I was involved with, which looked globally at the differences between Axi-cel and Tissi-cel. And again, in this study, we saw better outcomes in terms of overall survival, progression-free survival, response rates. And of course, the significant difference between the two products is the rates of significant neurotoxicity. So grade 3 and above ICANS being I think is a significant finding. And actually, grade 3 and above cytokine release syndrome, so the more serious forms of CRS resulting in ITU admission, is not actually different between the two products when you look at it this way. I think it's worth noting that outcomes are actually improving. This is an abstract presented at ASH, but it's in press for full publication. And it looks at the King's data, but also the UK national data, and we see very significant improvement in lymphoma CAR-T outcomes. And I think it's just worth noting, you know, when you set up a national CAR-T program, it's very challenging at the beginning. Many patients come out the woodwork who have been waiting for CAR T, who are highly relapse refractory. I mean, the sort of patients we were referred to at the beginning compared to what we get now, it's completely different. We were receiving patients from around the country with very significant bulky refractory disease, and we just treat people a lot earlier now. And as a result, I think this, we're seeing improvements in PFS and OS. Certainly, CAR T toxicity management has significantly evolved as well. We are intervening much earlier with tocilizumab and particularly steroids, and I think there's enough data now to show that it doesn't affect outcomes. So I think we're much more relaxed about using steroids for management of CAR T toxicity. Which brings me to really the main question of the talk, which is regarding CAR T versus autograft. Now, it's never a straightforward question because it's not really CAR T versus transplant. It's CAR T versus standard of care. ASH last year was very interesting because we saw 3 presentations for the 3 main products, liso-cel, tiso-cel, and axi-cel. The tiso-cel report was essentially negative, so I won't present that further. And liso-cel is not available, and the results were very good. But that trial was is quite significantly behind this paper, which is really an incredibly important practice-changing report, and it's sort of the first time second-line DLBCL management can objectively be changed in 25 years. So this is ZUMA-7 axi-cel versus standard of care. So yes, it's important to stress this is not axi-cel versus transplant, it's axi-cel versus standard of care. So standard of care is 2 or 3 cycles of platinum-based chemotherapy followed by an autograft if patients respond with a CR or PR. And the other arm is axi-cel. Like all of the ZUMA studies, bridging was not really allowed. I mean, you were allowed to give dexamethasone or radiotherapy, but no chemotherapy bridging was allowed, which is very different to real-world practice. Certainly in the UK, the vast majority of patients will be offered bridging, I think up to some 80 to 90% in the paper that was published in Blood Advances earlier this year. And the primary outcome measure in this trial was event-free survival, but they also looked at overall response rate, overall survival, and certainly safety. CAR T toxicity, I think, is very interesting. It's worth highlighting the sort of patients coming through to this study were very high risk. There was a significant proportion over the age of 65, but particularly I think it's worth noting that around 3/4 of the patients who got onto this trial had primary refractory disease. And of course, if we look at historic data, these are patients we don't think would do very well with transplant, but certainly many of them historically end up having transplant because of lack of other options. Certainly now in my second-line practice, this is what I'm seeing. The vast majority of second-line CAR T referrals that have primary refractory disease rather than relapse within 12 months, but the eligibility does go out to relapse within 12 months of first-line therapy. So specifically, that means relapse within 12 months of the last cycle of first-line chemotherapy. If we look at the plot, it's quite striking that on the CAR T arm, the vast majority of patients did actually receive axi-cel, 94%. But if you look at the transplant arm, only 36% of patients actually had transplant. And of course, this is because patients did not have an adequate response to chemotherapy, which seems really quite a low percentage. But in the other second-line studies, it was similar. And I think it's also really worth noting that this is not a crossover study, but this trial was predominantly done in countries where there was good access to third-line CAR T, so the vast majority of people that did not have transplant or relapse post-transplant actually went on to have third-line CAR T, 57% of patients, but they did so off-protocol. And when you look at axi-cel versus standard of care for overall survival, we see this significantly improved overall survival for axi-cel in this very high-risk group of patients. And this is even acknowledging that 57% of patients in the standard of care arm went on to have CAR T in third-line plus anyway. So this is, I think, is a strong argument for the use of CAR T second-line. And it's certainly very convincing data, in my view, that we should be offering CAR-T versus over transplant. And the caveat that this is in the identified patients who are eligible for this trial, so primary refractory and relapse up to 12 months. Again, we see significant improvements in progression-free survival. Again, very convincing curves. So really, this is a practice-changing study where we see Axi-cel is better than standard of care in terms of overall survival, progression-free survival, and really this has resulted in significant changes in our pathway in the UK. So I realize this is everything's changed with the DLBCL this year compared to the previous years. So our whole pathway has changed, and I realize some of your ability to change this depends on reimbursement and access to CAR-T. But certainly, I think the point I'm trying to make is we are convinced by this data, and the regulatory authorities in the UK have been convinced by this data. So we have been allowed to immediately change our pathway. So in data not presented, there's the Polar first-line paper, which has resulted in us being allowed to use Polar R-CHP for first-line DLBCL for IPI 2 to 5, but some patients will still continue to get R-CHOP. At the point where they are refractory or relapsed, these patients should be discussed with somebody like me, so somebody that gives a transplant or CAR-T opinion in one of the big CAR-T centres. The UK has defined CAR-T eligibility on the basis of transplant eligibility, just because that was written into the ZUMA-7 protocol. So we're only allowed to offer second-line CAR-T to people who we would consider to be eligible for transplant. So in practical terms, this really means patients up to the age of 75. So now anybody who is relapsed refractory within 12 months of their last cycle of first-line chemotherapy with DLBCL or transformed follicular or marginal, we would take them to Axi-cel second line as our standard of care. Patients who are relapsed more than 12 months or have primary mediastinal or Richter's, we would still go down the conventional salvage transplant route. Our salvage of choice is 2 times RGDP. I would highlight my experience of offering third-line CAR-T. We now always make a CAR-T decision after 2 cycles of salvage. We don't continue giving salvage, changing salvage for patients who are potentially CAR-T eligible, because I think it's not in their interest. I think it's good to make a CAR-T decision as soon as possible and then just move on. Obviously, they can have more chemotherapy as bridging, which would be the norm in the UK. So we are still doing autologous stem cell transplant, and I still think there is a clear role for autologous stem cell transplant, but it's really in the patients who are less high-risk relapses. So anybody who relapses more than 12 months after first line, we still give them a transplant as standard of care, and there is some issues about specific histologies that have to go down that pathway as well. Just a little bit about post-CAR-T relapse, because people usually ask. This is my personal opinion. People who relapse post-CAR-T with stage 1 disease, we definitely give radiotherapy as standard. Other options including any remaining polatuzumab. Glofitamab has just been approved in the NHS as third line. Tafasitamab-len is available. Compassionate access, R² is usually available. Compassionate access. Checkpoint inhibitors. I personally am not very keen in DLBCL, but certainly in primary mediastinal B-cell lymphoma, I would do so. And we would consider consolidating any post-CAR-T relapse remission with an allograft, but only in very selected fit patients with a good donor. And I think, certainly before access to bispecifics, people who have primary refractory disease to CAR-T, so I'm talking about the people who are progressing day 10, 20 by the first PET scan. I'm not talking about people who respond and then relapse at the 3-month scan, but people who are primary refractory to CAR-T, often best supportive care is the most appropriate course of action, because to progress through CAR-T is a sign of really horrible disease. Whether we change this approach now that we have more access to bispecific antibodies, we will see. A little note about transplant and stem cells you have in the bank. I think there's this interesting data coming through now about how we manage post-CAR-T cytopenias. Severe post-CAR-T cytopenias in lymphoma are not that common, but certainly I have a number of patients who have had quite significant issues, transfusion dependence. And now I think there's fairly convincing retrospective data, at least, that if you have cells in the bank, it's worth giving them for post-CAR T cytopenias. They don't need conditioning, you can just give them. And certainly the patients that receive cells had much better outcomes in terms of infection than the other patients in this study. So, in conclusion, NHS results have shown third-line CAR T to be effective, manageable, and our outcomes are as good as the trial data since the National CAR T programme started. ZUMA-7 has changed everything this year for UK practice. We are now offering axi-cel over standard of care salvage autograft for patients with primary refractory disease and relapsed within 12 months. However, there is still a role for autologous stem cell transplant for DLBCL, and certainly for patients who relapse more than 12 months, that is still our standard of care option. But there's really interesting work to be done. You know, obviously the ZUMA studies didn't allow bridging, but in real world practice, bridging is usually needed. So optimal bridging strategies, the second line CAR T and sequencing and how we manage post-CAR T relapse, now that we've got all these privileged positions of having all these increased options, I think more work needs to be determined to determine the optimum management in these patients. Just a reminder, we have a post-CAR T and BMT fellowship for anybody who's interested. And thank you for your time.